Hi, Dr. Peterson here with Regions EMS. Let's take a few minutes to review our updated trauma guidelines. Fortunately, there are not many significant changes as the definitive management of trauma occurs in the hospital setting. We'll start with Guideline 55, Multiple Trauma. All of the trauma guidelines apply to adult and pediatric patients alike. The multiple trauma guideline should be utilized anytime more than one isolated injury is present. For patients with potentially severe injuries, the scene time should be minimized to less than 10 minutes if possible. Airway management is important, but can also be performed en route to the hospital in most cases. Major hemorrhage control and chest needle decompression would be the critical interventions once the airway has been secured. IV fluids are only necessary to maintain a systolic blood pressure of 90 or a palpable radial pulse and should not be given unless there is a clear indication. Pelvic binders should be used if there is a suspicion for pelvic fractures, typically with significant falls or motor vehicle accidents. Once you have appropriately managed the immediate life threats, you should make sure your patient is kept warm to prevent even mild hypothermia. This can complicate bleeding problems in the hospital. Patients with significant or multiple injuries should be transported to a trauma center, and those meeting physiologic criteria should have a trauma team activation requested. The back side of Guideline 55 lists the current trauma center diversion and TTA criteria and should be familiar to EMS providers. Guideline 56 should be used for any patient with suspected head trauma. These patients need evaluation in a trauma center, especially if there is any alteration in mental status. The key pre-hospital considerations are to limit the secondary injury to the brain, which can occur with hypoxia, hypovolemia, and increased intracranial pressure. Oxygen should be given and titrated to keep SATs above 94%. IV fluids should be given to maintain a blood pressure of at least 90 systolic, and the head of your cot can be elevated to reduce the intracranial pressure. If you observe signs of brain herniation or imminent hemodynamic decompensation, hyperventilation can be considered to achieve an end-tidal CO2 level of between 30 and 35. Guideline 57 is new with the 2014 guidelines. We now have more evidence that backboards may cause harm when used unnecessarily. This guideline is intended to identify patients who do not need to be immobilized to a backboard, but keep in mind that the default will still be to immobilize anyone with a high-risk injury or with any neurologic symptoms or pain. Those with prior neck or back problems, the elderly, and anyone with any evidence of intoxication by any substance should be fully immobilized, as the risk of a spinal injury is much higher in these patients. A key point to mention is that securing a patient to your cot without a backboard is still an appropriate means of maintaining spinal precautions. This should be communicated to the receiving facility that you have not definitively cleared the patient's spines. Guidelines 58 and 59 deal with extremity trauma and crush syndromes. Extremity trauma management has not changed significantly and will not be reviewed in this video. Crush syndrome is a condition that should be suspected whenever there is prolonged entrapment of greater than 30 minutes. Crush syndrome results from muscle damage and limb ischemia resulting from prolonged compression and entrapment. Although the patient may appear stable, once they are freed, the return of blood flow to the injured area can cause the systemic circulation of potassium, lactic acid, and other dangerous waste products which can precipitate cardiovascular collapse. For this reason, it is very important during an extrication process to obtain an assessment by an experienced provider before the actual extrication is performed. If the entrapment will be longer than 45 minutes, tourniquets should be applied to the affected extremities, an IV started, and normal saline infused to support the patient's circulation. 2 amps of sodium bicarb, or 1 milliequivalent per kilogram for pediatric patients, should be infused immediately prior to the extrication in order to neutralize the effects of the lactic acid buildup. These patients should be carefully monitored throughout the extrication process for any changes in status and treated accordingly. You should also consider requesting an EMS physician through MRCC in cases of prolonged entrapment, as field amputation of a crushed limb might be another consideration for an unstable patient. Moving on to Guideline 60, let's talk briefly about eye injuries. There are really no critical pre-hospital interventions other than to protect the eye from further damage. For chemical exposures, tetracaine or proparacaine drops can be used for pain relief prior to irrigation, but they should be avoided in trauma. If there is any concern for eye penetration or rupture, consider administering Zofran prophylactically to prevent an increase in the eye pressure if the patient were to vomit. Otherwise, the eye should be covered after a pupillary exam and vision check, and the patient should be transported in a position of comfort. Guideline 61 addresses the management of thermal burns. The key decision in thermal burn management is to recognize those burns which would warrant transport to a burn center as described in the yellow and red boxes at the top of the guideline. Dry, clean dressings, pain control, prevention of hypothermia, and IV fluid resuscitation are the key management concepts. For fire victims, also consider carbon monoxide and cyanide exposure and treat according to the appropriate guideline. Any burn victim with evidence of respiratory symptoms, throat swelling, or vocal changes should be aggressively managed with early RSI before the airway swelling becomes problematic. The chemical burn guideline, or Guideline 62, is covered in a separate hazardous materials video. So let's move on to Guideline 63, electrical burns. This is very similar to the thermal burns guideline, and any soft tissue injuries should be treated accordingly. Obviously, your safety is paramount, so ensure that the electrical source is no longer a danger before you approach the patient. The key management point for electrocution injuries is to obtain an EKG. Any evidence of ischemia or arrhythmia should warrant concern for cardiac involvement. Let's move on to Guideline 64, blast injuries. Blast injuries or explosion injuries create additional considerations for patient care. Patients may have a variety of injury patterns, and the scene may require the use of MCI triage principles. Any specific injuries should be treated according to the relevant guidelines. A unique consideration for blast injuries would be the presence of a pneumothorax from the blast shockwave, even in the absence of a penetrating chest wound. This condition is often referred to as blast lung injury. If an MCI is declared, please notify MRCC early to prepare the receiving hospitals. Also, consider requesting an EMS physician response to assist with triage and transport determinations on scene. The final guideline for this video is Guideline 66, the Drowning and Submersion Injury Guideline. Now, this is important considering the abundance of lakes and the variation in weather patterns that we see around the Twin Cities. If the incident involves a scuba diver, consider involving medical control to determine the appropriate destination. In some cases, it may be most appropriate to transport the injured diver directly to a hyperbaric-capable facility. The Divers Alert Network, or DAN, contact information is given on the back of the guideline and could be used for further advice as well. For any drowning victim, the treatment should be determined by their mental status. All patients should be transported to a hospital for evaluation, as there is a high incidence of delayed lung problems even up to 6 hours after submersion, even if they have no symptoms on your initial evaluation. If there is any alteration in mental status, consider aggressive airway management as you see appropriate. A PEEP valve should be used if a BVM is necessary to provide positive pressure ventilations. If the patient is found to be in cardiac arrest, you will need to decide if resuscitation attempts are appropriate. Although there is a higher chance of survival in cold water, even with prolonged submersion, the chance is still low. If the submersion time was less than 60 minutes, you should consider to transport with active resuscitation efforts. Medical control can assist with this decision if needed. Over 60 minutes, it is extremely unlikely that the patient will survive, but you may still consider resuscitation for pediatric patients, those with any signs of life, or if there is visible ice on the water or the measured water temperature is below 70 degrees. Rescue and recovery efforts underwater pose significant risks to rescuers, so determining a threshold after which resuscitation efforts would not be initiated might be helpful to the incident commander for safety purposes. This decision should be clearly communicated, and should also involve medical control if there are any questions or extenuating circumstances.